Good evening, ma'am.
Good evening, da. Start pannalama
Good
or you want
evening.
to some more time?
Ma'am, we can start, ma'am.
Okay, Raja. Okay. So who's presenting? Dr. Ramya. Okay, Ramya. Start, Rakana.
Good evening, ma'am. I am Ramya Shri. I am going to present a case on multiple pregnancy. Mrs. Kavya, a 30-year-old female coming from Chulaimedu, homemaker by occupation and belonging to socio-economic class 4, has come to the OPD with 8 months and 2 weeks of amenorrhea with an obstetric score of G3, P1, L1, A1. She was booked and immunized at Chulaimedu PHC. LMP was on 3rd March 2020 and EDD is on 10th December 2020. Chief complaints: the patient has presented with 34 weeks of amenorrhea and she has been referred from Chulaimedu PHC to KMC for safe confinement of pregnancy with the complaints of swelling of legs on both sides for the past 4 weeks and shortness of breath for the past 1 week. History of presenting illness: the patient complains of pedal edema for the past 4 weeks, acute in onset, progressive in nature.
4 weeks இருக்கு அப்புறம் எங்க இருந்து acute onset இல்லையா? This patient, she is having the complaint for 4 weeks.
Okay.
So then it cannot be acute lapa. See, you
Okay,
cannot contradict your own statement, sir. Okay, well, she could have presented to Chulai clinic as acute maybe 1 day, 2 days இருந்திருக்கலாம். Then she could have come back to you later. But for you, she has been having a 4 weeks pedal edema, so which cannot be acute.
Okay, ma'am.
இல்லையா?
Okay, ma'am.
Okay, go ahead.
Progressive in nature, aggravated by sitting or standing and relieved by lying down. Shortness of breath for the past 1 week, acute in onset, progressive in nature, aggravated by activity and relieved by rest. Associated with history of excessive distension of abdomen and excessive fetal movements felt for the past 4 weeks. History of frequent micturition for the past 1 week. History of excessive vomiting in the first trimester. No history of conception with ovulation induction drugs and assisted reproductive techniques. No history of varicose veins or hemorrhoids. No history of easy fatigability and lethargy. No history of palpitation and chest pain. No history of decreased urine output, abdominal pain, headache and visual disturbances. No history of bleeding per vaginum.
Okay, so fine, like, let us go back. See, I think, like, now we are getting a patient who's been referred to us from some other PHC. So she has done an
Yes,
ANC for 32 weeks somewhere else. So definitely she would have had scans. Okay, va? So if
Yes,
it is
ma'am.
a fetal gestation, you can as well add that in the history. See, patient will also tell you that they told me that I have 2 kids. 2 பாப்பா இருக்குன்னு சொன்னாங்கன்றது ஹிஸ்டரியில பேஷண்ட் கண்டிப்பா சொல்லும் இல்லையா? See,
Yes,
only
ma'am.
if your patient doesn't know and you are sitting in a very, very remote village where there is not even one scan done, you can go ahead telling, like, not telling about multiple pregnancy at all. But here
Okay,
it's
ma'am.
not the situation. Ilaya, here your patient will definitely know that she is having multiple gestation. So,
Okay, ma'am.
like, see, first of all, whenever you present the history, see, first of all, you cannot start that, what is your case? Okay, multifetal pregnancy or multiple pregnancy in சொல்ல முடியாது. But your history should tell the examiner that இது வந்து multiple அப்படின்னு. So you can even tell her that, like, this was told to have multifetal gestation and she was referred here for safe confinement, so that it will give an idea. One. So go back to the next page, history ponga. So now what all is your inference? Swelling of legs, shortness of breath. So you tell me what all is your DDs? What all you're thinking in mind? What would be the problem?
Polyhydramnios, ma'am.
சரி, அதனால
because of that over distension of uterus and so pressure symptoms like swelling of legs and shortness of breath, ma'am.
Okay, fine. Okay, what else? But like, something you should think which is more important, more common and more life endangering or life threatening. அந்த மாதிரி உள்ளதான் first வரணும். Any patient, she comes to you with swelling of legs, shortness of breath. Think of common things. What all can be there? General medicine பத்தி யோசி. Forget she is pregnant. In medicine,
Deep vein thrombosis.
Excellent, because that is the most important DDs which you are going to think of. DVT.
Okay.
Why? DVT followed by shortness of breath. What is the diagnosis, sir?
Pulmonary embolism, ma'am.
Excellent. So because if you miss this pulmonary embolism, you're not going to put heparin for her. She's going to die. Correct? So your
Yes, ma'am.
DVTs should have most important things coming in front. So in the
Okay.
Madri history, the first thing which you're going to think of is DVT. But now you tell me what is against DVT in this patient. I'm saying she's not DVT.
Swelling of legs on both sides.
Excellent. Usually DVTs will have swelling unilateral.
Unilateral.
Because ரெண்டு காலையும் simultaneous DVT வருது is very, very rare. Still it can happen, but they are very rare. Unless and until a patient has a, like, you know, a previous history suggestive of DVT or previous pregnancy which is suggestive of bilateral DVTs are very rare. So bilateral, you don't think of DVT in this situation. Okay. Second common what I want to think of in this patient. Swelling, breathlessness. Medicine la yosing, obstetrics outre. Medicine la yosi. Obstetric person is also a medicine person. Medicine la enna yosipo?
Renal pathology.
Shortness of breath ka. Okay, ரொம்ப rare. அவ்வளவு யோசிக்காத, சிம்பிளா யோசி. நம்ம கண்ட்ரியில காமன்.
Filariasis.
Yeah. Anemia.
Okay.
Anemia. Swelling will be there. So swelling in the legs is suggestive of which heart failure?
Right heart failure.
Excellent, doctor. Excellent. Shortness of breath is indicative of?
Left heart failure.
Left heart failure, pulmonary edema. So your anemia leading on to heart failures, congestive heart failure, so that you can get both. Even per se anemia can also cause shortness of breath because you'll have easy fatigability and the hypoxia will be there, chronic hypoxia leading to shortness of breath. So you're going to think in terms of anemia too. Second, what else can be the other reason? The other one is heart disease.
Yes,
so in the history present user of these three DDs, which is your case அப்படின்ற மாதிரி ஒரு சின்ன clue இருக்கணும். So you can add, like this was told to have multiple pregnancy, so she's referred here with these two complaints. அப்படின்னு சொன்னா okay. Now thinking in terms of multiple pregnancy. So your patient with multiple pregnancy, these two complaints, what are you going to think of? Only you told me hydramnia causing pressure symptoms and hydramnia shifting the diaphragm, giving difficulty to breathe. So that is one. What else?
PIH.
Okay, varlam liya. Preeclampsia, so causing swelling as well as difficulty to breathe. Okay, what else?
Anemia.
Excellent. Anemia because it's more common in twins. So even with twins, not all twins will have shortness of breath. Okay, so adanala you should be very, very clear in what you are dealing with, so that you should know how all to elaborate. So negative history la nama vechirka other DD should also come as negative histories. Cardiac disease, illa suppose nariya patient ipa routine ave they do echo in the PHCs and government hospital. So if that has been done, that can also come as a negative history. A heart scan which was told to be normal, that means it rules out your heart disease. Correct?
Yes, ma'am.
Echo பண்ணிருக்காங்க, heart scan தான் patient சொல்லும். Patient will not give you that I have done an echo, they told me no AS no AR அப்படிலாம் சொல்லாது patient. Patient என்ன சொல்லும், ஹார்ட்டுக்கு ஸ்கேன் பண்ணாங்க நல்லா இருக்குன்னு சொல்லிட்டாங்க அப்படின்னு. அப்படின்னா heart disease ruled out. So those things, if it is there and if you're telling that, that will give added points to you, one, and that will also make your examiner understand that you know what you're talking about. உனக்கு என்ன தெரியும், நீ என்ன தெரிஞ்சு நீ பேசுறன்னு எக்ஸாம்ல தெரிஞ்சாலே நீ பாதி பாஸ் ஆன மாதிரி அர்த்தம். புரியுறதா? Okay, so go to the next slide. Now we'll go with each and every chief complaint or negative history. We'll elaborate. Next slide va. Okay, so pedal edema and idu sonnom. Okay, idu sollu. What else? So this excessive vomiting you're pointing towards multiple gestation.
Multiple gestation.
Okay, where else can you have excessive vomiting?
Molar pregnancy, ma'am.
Excellent. Okay, so these are the two things which you should remember. Why there is excessive vomiting?
Increased amount of trophoblastic tissue, ma'am.
Okay, so
So beta HCG will be elevated, which
yes,
leads
so
to
HCG
excess vomiting.
levels will be elevated, and that is the reason for vomiting. So here you have lot of placental tissue, so that's why you're going to get a vomiting in multifetal. Molar also you have lot of trophoblastic tissues. Okay, so அடுத்தது, now coming to your risk factors. So what all can cause multifetal gestation? இல்லையா?
Yes,
So
ma'am.
what are all the risk factors for multifetal gestation?
Maternal age,
Yes,
genetic
yes,
history, heredity, and assisted reproductive techniques.
yes.
Um,
What are all the assisted reproductive techniques you know? What all do we call by assisted reproductive techniques? நீ தானே சொன்ன.
yes.
நீ சொன்ன அப்ப ஃபுல்லா எக்ஸ்பிளைன் பண்ணனும்ல. Hey, anyone else can answer. சும்மா அவளே தனியா விடாதீங்க. Come on, somebody else.
Ovulation induction by clomiphene citrate.
Excellent. I wanted this answer. See, ART or assisted reproductive techniques, okay, includes only your IUIs, your IVF and ICSI. Okay. Or chumma ovulation induction, be it tablet or just adding injection gonadotropin to a ovulation cycle to produce ovulation is not called assisted reproductive techniques. Okay, va? So at least these, we are not going any assisting edum pandrathu kediyadu. So adanal assisted la just plain ovulation induction will not come. So that clarity should be there. So and per se by IVF or IUI is not going to increase. So it is mainly your ovulation induction. So what are all the ovulation induction agents you know?
Clomiphene citrate. No.
Yes. What is the other one which we use nowadays?
Gonadotropin.
Okay. What else? Clomiphene mari innor tablet.
Tamoxifen and letrozole.
Letrozole the commonly used. Tamoxifen we don't use commonly. Okay, ma'am. Sorry, okay. Now, what is the difference between your clomiphene and letrozole in ovulation induction? Which will cause mono-ovulation, monofollicular growth?
Letrozole.
Yes. So, adha nyabagam vechikkanum. So, when you give risk factors for ovulation induction, it is more of clomiphene and gonadotropin, but not letrozole. Most of the time, your letrozole is monofollicular growth. It can still cause, but it's very rare. So that is one. So family history, we have told her, okay, past, like previously she has had twins, we told her. Age, similarly, your multiparity and obesity and certain races have risk factors. Okay. So adanalada you have asked about ovulation induction and assisted reproductive techniques. Okay. So varicocele and hemorrhoids, why have you asked?
Due to pressure symptoms and pressure effects on the.
So what are all the other pressure effects you know? Respiratory difficulty, which we already told, the diaphragm மேல push பண்ணும், breathe பண்ண முடியல. Okay, மத்தபடி GI symptoms வரலாம். There can be constipation, there can be dyspepsia, there can be early satiety and other things. Okay, what is that easy fatigability and lethargy? Why have you asked?
To rule out anemia.
Excellent. So why is palpitation, chest pain?
To rule out heart diseases.
Okay,
also
because
anemia.
that is one of the DDs, because to cause leg pain and difficulty to breathing.
Yes, ma'am.
Enna ovvonu you should know why you are asking. Apana exam la nyabagam varum.
Yes, ma'am.
Priya, you cannot mug all histories, doctor, because you will forget in exams. So if you understand why are you asking each and everything, it's very, very easy to reproduce in the exams. Priya. So now decreased urine output, abdominal pain, headache and visual disturbances. Why?
To rule out imminent eclampsia.
Imminent signs. So if this patient is preeclampsia and whether she has imminent signs or not, you have asked all these things. Bleeding per vaginum, why?
Antepartum hemorrhage.
Yes, antepartum hemorrhage is more common. Which type of antepartum hemorrhage is more common in twins?
Placenta previa.
Okay. Innonna abruption. Idu rendla edhu irukko illa rendla edhu varum?
Placenta previa is more common.
Yes, both can come. Why does it placenta previa? Why does it occur?
Due to larger surface area of placental tissue in twins.
Very good. So the placental tissue, like single placenta way one side occupy பண்ணும்போது, when you have two fetuses, two big placenta, a large surface area, so part of the placenta will come to the lower segment. So அதனால placenta previa is more common with twins. Very good. Why is abruption common in twins?
Um, because of over distension of uterus.
Okay, over distended uterus nala mattum varadu, when suddenly that over distended uterus tries to shrink. Like for example,
Yes,
if there
ma'am.
is an PROM or some water is getting leaked, on the time there can be abruption. That is one of the reason.
Okay.
Okay, what else? இப்பதான் நம்ம சொன்னோம், preeclampsia, hypertension is more common to twins. So that is
Yes,
one
ma'am.
of the reasons for your abruption also.
Okay, ma'am.
Okay, so bleeding per vaginum can be both. Okay, next slide.
Present obstetric history. Pregnancy occurred by spontaneous conception after 6 years of birth of the first child. Pregnancy was confirmed by urine pregnancy test at Chulamede PHC by 45 days. Booked and immunized in Chulamede PHC. LNP is 3rd March 2020 and EDD is 10th December 2020 with gestational age of 34 weeks currently.
Okay,
First
so
trimester.
I'm going to talk about the interpregnancy interval later on.
No contraception was used.
No contraception.
And there was an abortion after 10 months
In
of
between.
consumption.
Okay, so now if you're asking about contraception, what is the contraception history which is very very pertaining to your multiple pregnancy? எந்த contraception யூஸ் பண்ணா அது நிறுத்துற உடனே உங்களுக்கு மல்டிபிள் பிரெக்னன்சி வரலாம்?
Oral contraceptives.
Yes, it has been seen in studies that oral contraceptive pills, after a period of time, when you use it for a long time and then you stop, a rebound increase in FSH can happen, and that can result in multiple pregnancy. So if a patient has taken oral contraceptive pill, then it's very important to mention it here. Okay, ma'am. Sherry, go ahead. Next slide.
First trimester, dating scan done at 12 weeks and revealed twin pregnancy. History of excessive vomiting present. No history of bleeding per vaginum or discharge. No history of fever with rash. No history of burning micturition. No history of radiation exposure. No history of chronic drug intake. Folic acid tablets were taken regularly. All baseline investigations were done and found to be normal. Number of antenatal visits 2. Second trimester, quickening felt at 18 weeks. TD injection, 2 doses were given. Iron, folic acid and calcium tablets taken regularly. Anomaly scan was done at 20 weeks and found to be normal. OGCT done and found to be normal. No history of pedal edema present. No history of breathlessness, fatigue and palpitations. No history of headache, visual disturbances, epigastric pain and decreased urine output. No history of polyuria, polydipsia and polyphagia. No history of discharge, bleeding or spotting per vaginum. Number of antenatal visits 3.
Okay.
Third trimester.
Yeah, go ahead. Yeah, go ahead.
Third trimester, excessive fetal movements felt. History of pedal edema. History of frequent micturition. No history of gestational diabetes, suggestive of gestational diabetes mellitus in PIH. No history of discharge or bleeding per PV. Iron and folic acid tablets were taken regularly. Growth scan was done at 30 weeks and was found to be normal.
Okay. See, these are usual histories, like there's nothing much to be done with every trimester history. It's not going to be there. Only thing you have to mention about vomiting. So fine. Yes, so now imagine your patient is very educated, okay, and she understands about chorionicity. Okay, so what is chorionicity?
Indicates the number of placenta for the baby.
Okay, so either the number of placenta and how the twins, like intertwin membrane. That is what we are more worried about. Okay, wow. Yes, so when is chorionicity best determined? Which period of gestation?
Around 10 to 12 weeks.
Usually it is in and around your NT scans, okay? So the
yes,
same 11 to 14 weeks, if you say, or 11 to 13 weeks is good enough.
Okay.
Okay, wow. Why should you wait for more than 10 weeks for this chorionicity?
Uh,
Okay, usually your amnion takes some time to appear and to, like, fuse with the chorion to give a clear cut number of layerings and other things. Okay, so unless and until in the first trimester you see two gestational sacs separately, we don't take it as, like, twins, like, dichorionic. So that is why we always keep it in the 11 to 14 week scan. Okay, so imagine a patient who comes to you after 14 weeks. Okay, so can you see the chorionicity very clearly?
chorionicity can be seen, ma'am.
Yes, but Anna, it is very specific only between 11 to 14. Once they cross 14, it's very difficult to say. As the babies grow bigger, it's very, very difficult to see the intertidal membrane. Okay, so you have to remember chorionicity is best determined between your 11 to 14. It's similar to your NT scan period. There is nothing much difference about it. Okay, fine. So go ahead with that. Next, radiation exposure. இதெல்லாம் நீங்க நார்மலா சொல்றதே தான். Okay, second trimester with this anomaly scans. Okay, what else can it be done with the second trimester scan other than anomalies?
Detection of twin to twin transfusion syndrome.
Yes, very good. Usually twin to twin transfusion syndrome occurs in and around 22 to 24 weeks. Okay, so usually if it is going to occur, it is going to establish before 24. So what type of twin they'll have twin to twin transfusion syndrome?
Monochorionic diamniotic.
Yes. Okay, monochorionic diamniotic twins will have most of the complications. Okay, so for those twins, when will the growth scan start? Usually we try to call the patient from 16 weeks, and ideally recommended is every 2 weeks you do a scan. Okay, but we can't do, like, so clearly for everybody, but this is what your guidelines say to pick up your twin to twin transfusion syndrome earlier. Okay, so once they cross 24 to 26, and till that time, if your TTTS is not developed, the chances of this developing later is very, very less. It doesn't develop after that. Okay, fine. So go ahead, go to the next slide. Yeah, third trimester, again, same thing. So first, third trimester history, you want to rule out anemia. So all the history, suggestive negative history should be there. You want to rule out preeclampsias, and you have to say, because increased placental tissue, increased counter-regulatory hormone, so you will have GDM. You have to rule out APH, so that your bleeding and other things comes. Patient may have preterm labor, so that is why you will ask other things like white discharge and other things, so that you will rule out preterm labor also. Okay, okay, fine. Go ahead.
Menstrual history, age of menarche 13 years, regular cycles 5 for 30 days, moderate flow 3 paths per day, not associated with pain or clots, LNP 3/3/2020, EDT 10/12/2020. Marital history, age of marriage 23 years, duration of marriage 7 years, non-consanguineous marriage, no history of contraception use.
Very good.
Past obstetric history, conceived spontaneously after 2 months of marriage and confirmed by UPT. Age at first childbirth 24 years, 6 years back. No antenatal, intrapartum or postpartum complications. Spontaneous onset of labor pains. Full term normal vaginal delivery at Gkmc. Male baby weighing 3 kgs. 6 years, alive and healthy. Baby cried immediately after birth. Breastfeeding was initiated within 1 hour and continued up till 2 years. No history of NICU admission. Second conception occurred 10 months after first childbirth and aborted after 2 months of amenorrhea by tablets at nearby private hospital because of accidental pregnancy. Resumed period 1 month later, and post-abortal period was
like we can change it as unplanned. Okay. It looks really, really different to me to say that it is an accidental pregnancy. So let us say because it was unplanned and they were not doing that. It's fine. Okay.
Okay. Past medical and surgical history, not a known case of diabetes, hypertension, tuberculosis, asthma or epilepsy. No history of thyroid disorder or heart disease.
See, no I history can't see the screen. Everybody else is seeing.
Yes, ma'am, it's visible.
Okay. Yeah, got it. Okay, go ahead.
No history suggestive of APLA, no history of previous surgery, no history of chronic drug intake, no history of blood transfusion.
Why suddenly APLA is coming in twins? See,
She
unless
had previous abortion, ma'am, so recurrent abortion.
அடி வாங்க போற நீ. இது abortion உங்க ஊர்ல definition.
No, ma'am.
Patient had accidental
MTP.
pregnancy and she went and did MTP. இல்லையா? அதுக்கு APLA வேற ரூல் அவுட் பண்ணுவோமா? See, unnecessary traps you should not fall into. Okay, va? If you go into that, see, for example, if your examiner is bored of twins and he's not planned to ask you any questions of twins, so he must be finding some loopholes to ask some other questions. And you give him a very beautiful topic to be discussed, which is APLA. Okay, so APLAs are more common with recurrent pregnancy loss. Okay, so this is one trap you're going to give him, so you're going to fall into that. That is one. Second,
ma'am, your audio is not heard.
hear me?
Yes, ma'am.
Okay. Yeah. So that is why I don't think you should mention about APLA and all for MTPs. Okay. So you should be very clear about spontaneous abortions and APLA. Okay. In history, what kind of history will you think of APLA?
Recurrent
What
pregnancy
all
loss.
Okay. So recurrent pregnancy loss, which is how many numbers? 3. Excellent. 3 pregnancy loss before
second trimester.
Before 10 weeks.
Okay.
Okay, 3 pregnancy loss before 10 weeks, or even 1 pregnancy loss after 10 weeks. That is, your FHR has come and then you have had a loss. That is one.
Okay.
Or even 1 stillborn or IUD. Okay, IUD.
Okay.
Or early onset preeclampsia or IUGR less than 28 weeks. Okay, so these things only you should think of APLA. If your patient has any of these, then you can go ahead and mention about APLA. If your patient doesn't have any of these, then you should not open your mouth about that. Okay, va? Go ahead, doctor. Go ahead.
Personal history: consumes mixed diet, normal bowel and bladder habits, normal sleeping pattern, 8 hours at night and 2 hours at day, no history of alcohol intake or smoking. Allergy history: no history of allergy to known
Very
allergens
good.
or drugs.
Always mention about allergic history. It's very, very important. It's one of the patient's safety information which you have to ask in every patient. Okay. Fine. Why? What is the rest recommended for twins?
Towards term, more of rest is required, ma'am.
24/7. Bed விட்டு அசையாத தூங்கிண்டே இரு. என்ன more of rest? You should be very well defining, இல்லையா?
Yes, ma'am.
See, usually the advice is just an extra 1 to 2 hours of rest in the afternoon. அவ்வளவுதான். Twins-க்குன்னு சொல்லிட்டு extra rest எல்லாம். மத்தபடி it's not that you should always sleep in the bed எல்லாம் கிடையாது. Okay, so minimalistic physical activity, they should not strain too much, but in rest of afternoon la or a small nap of 1 to 2 hours should be fine. Okay, va? Sure, go ahead.
Okay. Family history: no family history of twins, no family history of congenital anomalies.
Very good.
General examination: patient is conscious, oriented, moderately built and nourished, no pallor, icterus, cyanosis, clubbing or lymphadenopathy, bilateral pitting edema, pedal edema of grade 2.
Okay, can you tell me the grading of pedal edema?
Ma'am, grade 0 is no edema, grade 1 is 2 millimeter or less and it disappears rapidly. Grade 2 is 2 to 4 millimeter indent and
millimeter வந்து சொல்ல முடியுமாயா? Millimeters of pedal edema va? எவ்வளவு தூரம் உள்ள போயிட்டு வருதா? This is how you grade pedal edema. Very good, doctor. I got some answer. Up to the ankle is grade 1. Very good. அதே மாதிரி இப்போ ankle அப்புறம் என்ன வரும்? Knee. Very good. Up to the knee, you take it as grade 2.
Okay, ma'am. And thighs.
Yes. So you get like anasarka madri போயிடுச்சுனா grade 4 and abdominal wall edema in the back மத்த இடத்துலலாம் வந்துருச்சுனா you will get grade 3. If it is totally bloated, she is looking like one full ball of water, then it is grade 4. Okay, ma. This
Okay.
millimeter is very, very difficult to say, doctor. If you have an obese patient, how much it
Yes,
goes
ma'am.
in will differently differ. So now this is
Okay.
how I know. If there is any other teaching, you please tell me the reference. We'll see and tell you
Okay.
what it can be done again. Okay, go ahead. Next slide.
Vitals, pulse rate is 80 beats per minute, normal in rate, rhythm, volume, and character. All peripheral pulses felt and no radiofemoral delay. Blood pressure 110/70 millimeters of mercury, measured in the left arm in sitting posture. Respiratory rate 22 per minute, regular in rhythm and thoraco-abdominal type. Temperature is 98.4 degree Fahrenheit and afebrile. Anthropometry, height is 155 centimeters. Pre-pregnancy weight is 58 kg. BMI is 24.1. Current weight 74 kg. Total weight gain 16 kg.
What is your comment about total weight gain?
Total weight gain is higher than the normal weight gain during pregnancy. And maybe it is because of multifetal gestation.
Yes. Usually for multifetal gestation, this is the weight gain which you recommend. Okay, so
Okay,
she's
ma'am.
not grown so heavily than the previous weight. Okay, fine.
Okay.
Go ahead, doctor. Go ahead.
Systemic examination, CVS, S1, S2 heard and normal, no murmurs. Respiratory system, normal vesicular breath sounds heard. CNS, no focal neurological deficit. Examination of breast, spine and thyroid were normal. Obstetric examination, after obtaining consent, patient is asked to empty the bladder. Then abdomen is fully exposed from xiphisternum to pubic symphysis with other parts covered and examined in dorsal position with semi-fixed thigh.
Excellent. Go ahead.
Inspection, abdomen longitudinally enlarged and over distended, umbilicus is in midline and is everted, striae gravidarum present, linea nigra present, hernial orifice is free, no scars, sinuses or dilated veins. Palpation, after correcting dextrorotation, fundal height corresponds to 36 weeks of gestation. Multiple fetal fats are felt over the abdomen and fluid thrill is not present. 2 fetal heads with multiple limb buds felt. Symphysiofundal height is 38 centimeters and abdominal girth is 95 centimeters. Fundal grip, hard, round, independently ballotable fetal part felt on the left side, probably the head. Broad, soft, bulky, not independently ballotable fetal part felt on the right side, probably breech. Umbilical grip, smooth, curved, hard, uniform resistance felt on both sides. First pelvic grip, hard, round, independently ballotable mass felt on the right side, probably head, and broad, soft, bulky, non-independently ballotable fetal part felt on the left side, probably breech, and second pelvic grip presenting part was not engaged. Auscultation, 2 fetal heart sounds were heard, one on the right side and another on the left side. FHR of right twin was 132 per minute and FHR of left twin was 145 per minute.
So once again, let us go back to examination. Okay. So in examination, no, we'll go to obstetric examination. Inspection, we'll go to palpation. Depending on your okay. How will you tell that this patient is having a twins? How many fetal pulse should you at least feel to say that yes, the obstetric examination shows a twins?
2 fetal heads or at least 3 fetal poles.
Yes, excellent. So it should be 3 poles, okay, with 2 heads. Ideally, you should feel both the head to say yes, that's the twins. Okay. So go back to your next slide, fetal heart rate. So how I mean, like, I feel it is little incomplete. How well should you say?
Difference of 10 beats per minute present.
Yes. What else?
Distance between the two heart rates. The
Yes.
heart simultaneously.
Yes. So simultaneously, so you alone cannot be doing it, yeah.
Yes, ma'am. Yes, ma'am.
So that should also come.
Okay, ma'am.
Okay. So if they ask you whom did you call, you can say my invigilator or my examiner or somebody else. I called them. So the twins' heart rate is by two independent observer, two heart
Okay, ma'am.
rate, which is heard at the distance of at least 10 centimeter apart, and the difference between the heart rate is at least 10 centimeter, 10 beats.
Okay,
Okay,
ma'am.
so it should be at least you should mention that it's done by two observers. Because
Okay,
by the
ma'am.
time you go to the second part, the baby could have moved, the same heart can be heard that side also. So,
Yes, ma'am.
adhikaga you should say that it is observed simultaneously. Very good, doctor. Go ahead.
Summary, Mrs. Kavya, a 30-year-old pregnant female with obstetric score G3P1L1A1, LMP of 3rd March 2020 and EDD 10th December 2020, came at 34 weeks of gestation with over-distended uterus, pressure symptoms and respiratory symptoms with twin pregnancy, fundal height corresponding to 36 weeks of gestation and multiple fetal parts felt. She has two live fetuses, one in the cephalic presentation and another in breech presentation with two separate normal heartbeats.
Okay. See, usually, no, doctor, like when we say over distension, okay, it is 36 weeks of fundal height, okay, with
Okay, ma'am.
flanks full.
Okay, ma'am.
Okay, so that is a term twin.
Okay, ma'am.
Okay, that is how we sway. But for a 34 weeker with the third fetal, I mean, like in a fundal height of 36 weeks, I mean, like unless and until she has hydramnias or something like that, it may not look like that over distended. So, like you should, able to differentiate. If it is not looking that bigger, just a little larger for date, then you need not mention it as over distended uterus.
Okay,
Okay,
ma'am.
fine. So
Okay,
now you
ma'am.
tell me which are all the conditions where you have a fundal height more than the period of gestation.
Um, Multiple pregnancy, polyhydramnios.
Yes.
Um, in case of fibroids or other masses,
Yes.
when the macrosomia in cases
Yes.
of diabetes.
Very good. Even your diabetes, big babies. So
Yes,
your
ma'am.
post maturity, whenever you have a bigger baby, yes. And what other one is baby can be big, so the uterus is distended. What else can be there? Wrong dates, excellent. What else? ஒன்னு பாப்பா
Um,
இன்னொன்னு என்ன இருக்கு உள்ள
uh, placentum.
செத்தா பிக் ஆக முடியாது இல்லையா வேற
Yes, ma'am. Uterus itself is enlarged
அத
in
ஃபைப்ராய்ட் சொல்லிட்டோம் அத தவிர வேற
fibroids.
எதுவும் என்லார்ஜ் ஆகாது தண்ணி நிறைய இருக்கலாம்ல
Yes, ma'am.
polyhydramnias singleton
Polyhydram.
can also have polyhydramnias இல்லையா
Yes, ma'am.
so these are the regions where you are going to have your gestational age like your fundal height is going to be more than the gestational age okay where which are all the conditions where you are going to have a fundal height less than the period of gestation small uterus
IUGR.
excellent IUGR
And
அப்புறம்
oligohydramnia also.
excellent oligoamnios
In case of post-term baby, there will be oligohydramnios, and so
அதெல்லாம் ரொம்ப ஓவர் டெஃபினிஷன் post term babies tend to be bigger also they can be macrosomia also see post
yes,
term you
ma'am.
cannot say low for இது வேற யோசி so you are measuring your symphysis fundal height இல்லையா so அது
Yes,
மட்டும்
ma'am.
கம்மியா இருக்கு excellent doctor transverse lie okay
Okay,
see
ma'am.
this is fetal uterus okay imagine your baby is going to lie like this longitudinal lie so then it will be corresponding okay but imagine a baby is going to lie like this and you are going to measure a fundal height so it will definitely be less
Okay, ma'am.
and always remember wrong dates
Wrong dates. And
okay so these are all the things
okay, ma'am.
incomplete abortion no that is in first trimesters and other things okay so whenever they are asking for symphysiofundal height what is the period where we see the symphysiofundal height when does
More than
your Yes, more than
20 weeks.
yes,
More than
usually பாத்தீங்கன்னா at the symphysis pubis கிட்ட எந்த period of gestation la uterus will be there? Umbilicus, the sternum. 12. Very good, very
12
good.
weeks.
So at 12 weeks la da it becomes like this. Okay, so appo vandu you don't see symphysiofundal height. At least it should go this 16, 18 or like your 20 to 24 la da நம்ம symphysiofundal height பார்க்க போறோம். At
Yes,
that
ma'am.
point, your incomplete abortions or missed abortions are rare, but still you can have intrauterine fetal death, especially in your third trimesters. அப்ப தண்ணியும் குறைஞ்சிரும் பாப்பாவும் வளராது, then it will again be less than your symphysis. I mean, like period of gestation will not correspond. Okay, so
Okay,
can you
ma'am.
sum up and tell me, Ramya, which are all the reasons where you'll have higher than the period of gestation?
Higher than the period of gestation, wrong dates,
Yes.
multiple pregnancy, polyhydramnios, macrosomia, tumors like ovarian or fibroid tumors.
Okay.
Then
Yeah, that should be fine. What are all the things which will cause less than the period of gestation?
oligohydramnios,
Yes.
in IUGR, transverse lie,
Yes.
intrauterine death,
Yes.
mistaken dates.
Yes, wrong date. So wrong date should always come. And yes, one more thing which you should always remember is full bladder. Okay, when your
Okay.
bladder is full, your uterus is tend to be little bigger. So that is why we always mention that the patient is examined with the empty bladder. So when you
Yes, ma'am.
mention that, then you cannot give a DD of full bladder because you have
Okay.
already told the patient to go and void and come. Correct?
Okay.
So
Yes,
you
ma'am.
should talk in exams with the questions pertaining to what it is asked. Okay, any more slides you have? Anything else you have?
Diagnosis and investigations.
Diagnosis and investigations. Okay, so she has 2 fetuses now, one in cephalic, one in breech. Okay, very good. But what is more important, which every examiner will want to know?
Um,
First twin in a presentation. So you have to give which is the first twin and which is the presentation in that. Okay, wow.
Okay.
One
Okay,
in
ma'am.
cephalic, one in breech is very, very incomplete. You should
Okay,
give
ma'am.
which is the presentation of the first twin. How will you diagnose which is first, which is second?
Mm,
Whichever is lower lying, okay, near the
Okay.
cervix, or whenever you palpate, whichever is like the first thing to palpate down, that is your
Okay,
first twin.
ma'am. Okay,
Okay,
ma'am.
so if that is cephalic, it will be like you can give normal delivery. See, for a multi with breech, it's a very controversial topic, but for your level, undergraduate level, if first of the twin is non-vertex presentation, you can definitely say cesarean section. You are not wrong.
Yes.
Okay, but if first
Okay.
of the twin is cephalic, then it is normal delivery. So you have to
Okay.
say which baby is head. Okay, va. So நீங்க கீழே தொட்டு
Okay.
பார்க்கும்போது in the first pelvic rib, whichever part is felt lowermost is the first of the twin. The other one
Okay,
will be second twin. Okay, va. Now go ahead, doctor.
Okay.
Next. So these are all the investigations. Thyroid profile. Why? Thyroid வருது?
Generally, we'll do
Generally, okay. So usually for a book 10 immunized women, you need not do all these HIV, HPV, she should have done. And anyway, she's been already, like in the same PhD she's done. So I don't think, like you have to tell all those things. If it is not
Okay.
done, you can do. Okay, va. But not for
Okay,
a booked women, definitely she would have done HIV, HPV, எல்லாம் பண்ணிருப்பாங்க. So, அதனால, I mean, like it is up to you. Okay, so now we have done the either. Okay, so let us go a little bit about discussion. So, what is zygosity? Okay, if you have completed, then can we stop the screening? Yes, you can just so that I can just take my whiteboard. Okay, so I want a few of you to discuss, answer. Let it make it interactive. Otherwise, everybody can go and sleep. Okay, wow. So let us make it interactive. What is zygosity? What is chorionicity? Are you there?
Yes, ma'am.
Yeah, zygosity, chorionicity. What is the meaning of zygosity?
Zygosity is the Number of ovums which gives
Yes.
rise to the twin.
Number of the ovum. Yeah. So chorionicity is nothing but your type of placentation. Yes, I completely agree with the answer. And zygosity is the number of ovum, ova or your embryos which is resulting in the pregnancy. So you have two type of zygosity. One is dizygous and another with monozygous. So what does dizygous mean? It is two separate eggs fused with two separate ovums and two embryos are formed. Okay, this is dizygous. So the dizygous twins are otherwise called as non-identical or what is the other name for non-identical twins? Fraternal twins. Benovular or fraternal twins. They will not look alike. Okay. And here monozygous, there is one egg which cleaves, one embryo which cleaves into two. Okay. And depending on the day of cleavage, you can have this placentation which is different. Okay, so dizygous are always dichorionic. And are two separate eggs. So this will have its own chorion, amnion. This will have its own chorion, amnion. So they are always going to be dichorionic. Okay, monozygous can be either dichorionic or it can be monochorionic, depending on which day of the embryonic life it is going to divide. Okay, so can anyone tell me about which day it divides and what are all the chorionic things which is possible? If the division occurs less than 2 days, what kind of placentation will be there? What is the type of twins they will have?
Diamniotic, dichorionic.
Dichorionic, diamniotic. Okay, fine. So if it is between 3 to 7 days, so it should be monochorionic, diamniotic. If it is more than 8 days, or even you can take it as 9 to 12 days. Okay, it is almost 3 to 8, 9 to 12 days, it is mono. And if it is more than 13 to 15 days, it is conjoint. Okay, see, these are all the favorite questions of your examiner. You are expected to understand these things. Okay, so let us go a little bit into what are these things. Okay, so we all know this is your uterus, and immediately covering your uterus you have something called as the chorion, and inside the chorion you have something called as amnion. Okay, and maybe around your like 10-12 weeks these two layers almost fuse, so you cannot differentiate in the scan by this, but after delivery you can separate these two layers and you can see. Okay, so in a dichorionic diamniotic twin, it means you have two chorions and inside these chorion you have one amnion here, you have one amnion here. So this is DCDA. Okay, so monochorionic is a single chorionic layer, and depending on whether these are the covering layers, if you have two amnions, it is MCDA, or if you have only one amnion, then it is MCMA. Why should you know this placentation?
Complications.
Complications are more with monochorionic twins.
Monochorionic.
Okay, so chorionicity. So that's why if the most favorite question is zygosity important or chorionicity important? So what should be your answer? Chorionicity is important. We are not bothered whether the one egg is coming, egg is separating or not, but how many layers are in between is more important. So chorionicity is very, very important because your perinatal outcome depends on chorionicity. Very favorite question. You have to remember this answer. Even if you are waken up from sleep, you should tell this. Okay, fine. So now let us see. This is a dichorionic twinning. Okay, So this is the baby 1 and 2. Everywhere you have 2 babies here. Okay, and here you have 2 babies. Okay, so this one will have a single placenta. Okay, so this is a MCMA twin. So here you can have 2 separate placentas. Okay, so either this can be in the anterior wall and this can be in the posterior wall. Sometimes you can have these two which is extending like this, and you can have a single fused placenta also. So both are possible in a DCDA twin. Puriyarda? It can be either 2 separate and 2 walls, or it can be one single big one which can be fused to appear as a single one. In the differences are very, very important. We can go slow. You have to understand these things, otherwise we cannot proceed further. Okay, va. Monochorionic again will have only, like 2 placentas which will be very close interacting. Okay, so there will be vascular connections here as well as here. Okay, what is one important complication which is very unique to MCMA twin?
Cord entanglement.
Cord entanglement. Excellent. What does that mean? Cord entanglement. So here there is no membrane between the two. So these two cords will be interacting with each other. There can be a formation for a true knot. Knotting madri or mudichu madri rendu cord ku naduvula vilundrum, because the babies will be constantly moving. There will be a true knotting. And if it is left alone, each baby can pull, the knot can get tightened, and it can cause fetal demise of both the twins. Okay, so this is very, very important. So when are we supposed to deliver this MCMA twins? Usually by 32 to 34 weeks. Okay, otherwise the risk of cord entanglement and the both the fetuses dying is very, very high. So that is more important, and MCMA is quite rare. Okay, of all the three, which is most common type? MCDA. Okay, we are talking about monozygotic twins. Okay, so in monozygotic, this is more common, which accounts for more than 70%. And this is about like around 30%. And this is very rare, about 1%. Okay, fine. So you should understand what is zygosity. Zygosity means which are one embryo which is splitting up into two, or is it two separate embryos which is forming? So one splitting into two, can they have different sexes?
No.
Excellent. Okay, so two different babies, abdina one boy one girl, instead of giving birth in different period, they have come together. Avladhan difference. So it is like brothers and sisters, or age gap illama they are born together. It's nothing but your fraternal twins. So every brother sister mari different ah irukum, adu rendum paaka ore mari irukadu, but still they'll be born together, they are twins. So that is called your fraternal twins. They are non-identical. They can have same sex, they can have different sex. இல்லையா ரெண்டு சில பேர் வீட்ல ரெண்டே ரெண்டு பொண்ணு தான் இருக்கும், கரெக்ட்டா? சில பேர் வீட்ல ஒரு பொண்ணு ஒரு பையன் இருக்கலாம். It's the same thing like that. ஓகேவா? இது எப்படி அண்ணா அக்கா எல்லாம் சேர்ந்து பிறந்துட்டா எப்படி வருமோ அவ்வளவுதான் வந்து your dizygotic twin. Just imagine whether your brother or sister is born along with you. It's the same thing. You can either have your same sex, you can have a different sex together. It can be like, your genotypically it will be very different, and it is more common with your IVF and other things. Okay, ma? Purinjada? Are we clear with this?
Yes, ma'am.
And monozygotic is when the twins split up. So the split ஆகும்போது it can be either two chorionic membrane in between, chorion illama verum amnion mattu it can be, or there can be no dividing membrane in between at all. Are we clear with that? Can we move on?
Yes, ma'am.
Okay.
Very good. So now how will you differentiate between these three? Monochorionic, dichorionic difference. Difference between these two. Okay, let me give you. Number of placentas. Placenta. Dichorionic, it can be either 2 or it can be a single fused one. Correct?
Yes.
Monochorionic, it will be only one placenta. Okay. So then what is the typical ultrasonic features which we see? One is twin peak sign. Second one is lambda. It is a twin peak or your lambda sign. And the second one is your T sign. And third one, the intertwin membrane or thickness. So now you tell me which is present in what?
Twin peak sign or lambda sign in dichorionic.
Excellent. So twin peak or lambda is seen in dichorionic. Your
And
T
membrane
sign
thickness.
is seen in monochorionic. Do you have any idea about what will be the thickness between the monochorionic and dichorionic?
Intertwin membrane வந்து dichorionic அதிகமா இருக்கும் because
So it will be thicker. So more than 2 mm thicker இருந்துச்சுன்னா அது வந்து dichorionic. Less than 2 mm இருந்துச்சு அப்படின்னா அது monochorionic. So these are the differences between these two. Okay, ba? So sorry, I thought of bringing you pictures, but see, usually what is twin peak sign or lambda sign? So you have your fetus, இப்படிதான் ultrasound ல இருக்கும். Okay, so you have a placenta over here. Okay, so imagine the placenta, the part of the placenta goes in between these two sacs. Okay, so this is called as your twin peak or your lambda sign. Okay, whereas in your that is your monoamniotic twin, monochorionic and diamniotic twin, you will have a very thin intertwin membrane. So like this, this is how we are going to see it in the ultrasound. Okay, so this is looking like a T. Okay, so this is the T sign and this is your lambda sign. Okay, are we clear with this?
Yes, ma'am.
So a part of your placenta, there is a placental projection between the two membranes which divides a twin. That is the lambda sign or twin peak sign, and this is the T sign. Usually this is a sign of chorionicity. So அப்ப எந்த ஸ்கேன்ல இது தெரியணும்? இப்பதானே படிச்சோம் 11 to 14 weeksல clear-ஆ தெரியும். Okay, ba? So in 11 to 14 week scan, if you see a lambda sign, then it is a dichorionic diamniotic twin, and if it is a T sign, then it is monochorionic diamniotic twins. Okay, are we clear with this? If anybody wants me to repeat, I'm there to repeat. So otherwise, we'll just go ahead. Okay, what is superfetation? So these are two favorite questions, not very important in your clinical practice, but there are many examiners who like to take this. Superfetation and superfecundation. Anyone heard of these? Anyone?
Superfetation is the fertilization of two ova released in different menstrual cycles, ma'am.
Excellent.
And superfecundation is fertilization of two different ova released in the same cycle by separate act of coitus.
Okay, so it means that one fetus is already sitting, the other fetus is going to come and sit, is superfetation. Simple words. So இது வந்து first menstrual cycle. For example, ஜூலைல இந்த pregnancy வந்திருது, இது நெக்ஸ்ட்ல வந்து ஆகஸ்ட்ல இது வந்து உட்கார்ந்தது அப்படின்னா it is superfetation. So two different menstrual cycle, two ovas are released and both go and sit together to cause pregnancy. Actually, this is very, very unheard in human, but there are many examiners who really like to ask these things. Okay, so two different menstrual cycle, there is your fertilization and this one occurs, implantation occurs, then it is superfetation. Superfecundation is, for example, one ova is come and sitting on say around like 10th of this month, and the other ova is going to come and sit around like maybe 20th of this month. Then it is like, same cycle, but different act of coitus it is come. Okay, so not very clinically important, but you should understand that these two words exist. Okay, wow, fine. So what are all the uses of ultrasound in twins? What are all the things that they will ask? Ultrasound எதுக்கெல்லாம் யூஸ் ஆகும் அப்படின்னு. First, to find the number of twinning. Okay, next, second, கடகடான்னு இதெல்லாம் கடகடான்னு சொல்லிடணும். ஓய் வாங்கயா.
Polyhydramnios and oligohydramnios.
Okay, நம்ம trimester வாரியா வருவோம். First, number of fetus. அடுத்து நம்ம முக்கியமா என்ன பார்க்கணும்? இவ்வளவு நேரமா என்ன சொல்லிட்டு இருந்தோம்?
Placental.
chorionicity பார்க்கணும். So you have to see the chorionicity. Chorionicity எப்படி பார்ப்போம் இப்ப சொன்னது சொல்லுங்க யாராவது? How all can you see chorionicity? அதானே சொன்னோம். Number of placenta, then lambda sign or T sign, இன்னொன்னு thickness of the intertwin membrane. இன்னைக்கு படிக்கல எல்லாரும். ஓகே, பரவாயில்ல, போய் இப்ப ரூமுக்கு போய் இதை திருப்பி படிச்சீங்கன்னா புரியும். Twins is a little difficult topic. It is very, very difficult to pass without reading this. Anala, please go read today. Okay, va? Second one is chorionicity. Okay, what else can you see? Anomalies. We said twins are more prone for anomalies. Then comes fetal growth. There can be growth discordance. There can be IUGS. So, adum paakano. Adukapram comes your liker, polyhydramnias, oligohydramnias, adellame varu. Then you can also say about preterm labor. Scan la preterm labor eppadi kandupidipom?
நம்ம cervix oda shape and length.
Excellent. Cervix length is very, very important. Shape is also very, very important. Usually your cervix will be a little curvy linear like this. ஓகேங்களா? அப்படி இல்லாம உங்க cervix straighten ஆகுதுன்னா, this is one of the early signs to say that the patient is going in for preterm labor. Little like PG level, but it's very good that you answer. And then comes your ultrasound guided procedures. So என்னென்ன procedure twinsல பண்ணலாம்? Have you ever heard of anything? Okay. Fetal reduction கேள்விப்பட்டிருக்கோமா?
HCl injection.
Yes. HCl, hydrochloric acid.
Sorry, KCl, potassium chloride.
Potassium chloride. Okay. KCl. Why can't we give methotrexate? கொடுக்கலாமே, ஏன் கொடுக்கூடாது? கொடுக்கூடாது is the right answer, but ஏன்? அதான் question. Why KCl? Why not methotrexate?
Teratogenic to other fetus.
Yes, very good. And there can be systemic absorption. It can also make the other fetuses die. Okay, so that is why when you have this good ongoing pregnancy, you give KCl. Where do you inject KCl?
Cardiac, intracardiac.
Excellent. Intracardiac. So you just see if idha irukku abdina, usually this is done between your and the 11 to 12 week scanner. Suppose if you have triplets, so moonu papa inga ukandundirukku and you have it like 3-4 membrane inga irukku, like ellame vandu trichorionic, triamniotic, whichever is most accessible. And suppose if this baby is more abnormal, then you go in the baby oda heart papo, then you put a needle inside, you inject KCl into the baby, and then you take out the needle, wait for this baby's cardiac activity to stop, and then you can send the baby home. Okay, va? So this is done in either triplet or higher order pregnancies. Usually for twins we don't do. Okay, va? Sometimes one of the drawback is all the baby can get expelled about ayadla. அதனால வந்து they will not do it for twins. So ஒண்ண வந்துட்டு நம்ம ரிடக்ட் பண்ணிட்டு அதுக்கப்புறம் செகண்ட் வெளியில வந்துட்டா ரிஸ்க்ன்றதுனால ட்வின்ஸ்க்கு பண்ண மாட்டோம் usually. But special circumstances you can still do. If it is higher order, more than 3, we definitely do. ஏன் மூணுமே பெத்துக்கோன்னு சொல்லலாமே? Why should we go and ask them to do a fetal reduction? Why are we asking for fetal reduction?
Comparing with twins, triplets la வந்து complications அதிகம்.
Excellent, because they land up with complication, they land up with preterm labor. So you can at least proceed till 32, 34 twins போலாம், 38 வரைக்கும் கூட போலாம். Triplets most of the time by 34 they land up with preterm labor. So the risk of prematurity, NICU stay and other preeclampsias, GDMs are very very common. You know, the more placentation is happening இல்லையா, அதனால we don't prefer a triplet pregnancy. Okay va, fine. So then what are all the maternal complications? So which you have already told, hyperemesis is one of the complication, miscarriages varala, anemia, GDM, preeclampsia and preterm labor. Never forget all these things. APH, which can be either placenta previa or abruption, and all your pressure symptoms. Okay, what are all the predictors of preterm labor? Preterm labor in twins, what all can predict? ஒன்னு நம்ம ஆல்ரெடி சொன்னோம், ஸ்கேன் பண்ணுவோம். ஸ்கேன்ல சர்விக்ஸ் ஓட ஷேப்பும் பார்க்கலாம், லென்த்தும் பார்க்கலாம். What else? Have you ever heard of fetal fibronectin? So fetal fibronectin, you do it in the serum. Usually it is done between this 28 to 32 weeks. If it is positive, then there is a risk for preterm labor. Okay. So what all can be done to prevent preterm labor in twins? Na pannalam. What all can be done?
Previous history of preterm labor இருந்தா progesterone can be given.
Okay, but usually studies have shown twins la vandu progesterone has very limited role. The only thing which they have like told to have some role enna konja rest vandu has found to have a use. Adu onnada vandu ipadikku irukku. Okay. And other things one that what I wanted to say is what are all the complication which is very particular to monochorionic twin? Complication which occurs mostly with monochorionic twins. Sorry, kekla. What is TTTS?
Twin to twin transfusion syndrome.
Thank you. Very good. Twin to twin transfusion syndrome. Okay, what does it mean?
There will be
Can
deep
someone
anastomosis between two
Yes,
twins.
there is anastomosis. Usually there will be anastomosis between artery to artery, vein to vein, and even like some artery to vein. Okay, but artery to vein is very very rare. These things will happen. Usually rend artery will have the same pressure and rend vein will also have the same pressure. They will not have much of complication with superficial. So whenever there is a connection between artery to vein, okay, what will happen? Ella in the artery irukka blood fulla vein of the other baby ku pogum. Okay, so that is the reason arteriovenous communication can cause twin to twin transfusion. So how will you diagnose twin to twin transfusion? Ennago, there will be connection at the level of placenta. So in the baby oda artery vein inga ukandittu irukom, innor baby oda arteryum veinum inga connect aidum. So in the level there will be some connections. So idukku pora nutrition vandu may get compromised. So what all can happen? Oru baby, so one is called as your donor twin, the other one is called as recipient. So oru papa lende innor papa ku blood porudhu appdi artham. So donor enna agum? The donor will become little small, IUGR irukum. So aduve vandu growth, blood flow adu ellame kammiyana adukku sutti irukka waterum kammiyagum. So in the பக்கம் அப்ப donor sac-ல வந்து என்ன ஆகும்? தண்ணி. What will happen to the liquor in the donor sac?
Oligohydramnios.
So recipient வந்து will get more blood. So this baby may also become bigger. It will be peeing more. So it will have a polyhydramnios sac. So it will be oligohydramnias, polyhydramnias. Then there will be a blood flow compromise, Doppler changes varla. Then this baby getting more of blood and or alavukku mela adukku blood vara then it will get ascites, ella pakkamo idukku water logging ella pakkamo idukku vara arambichirum vandittu then either one will die or both will die. Okay va, so this is your twin to twin transfusion. Okay, more common with your monochorionic diamniotic twins. So what can be the treatment which will be done for this, sir? They will do a fetoscopic procedure. So either the uterus, so they will put a scope here and laser vechittu in the communications ablate பண்ணுவாங்க. Okay, so on the communications ablate பண்ணிட்டாங்க அப்படினா the chances of further transfusions can be prevented and the babies have found to do well. Okay va, so that is like usually nalla extreme pochuna. What is the staging system for twin to twin transfusion? Anyone?
Quintero staging.
Excellent. So if you want to learn, you can even learn about Quintero, but அந்த லெவலுக்கு கேட்பாங்களான்னு எனக்கு தெரியல. Can you say what all the 5 stages of Quintero? ரொம்ப ஜாஸ்தியா இருக்கோ? சரி, no issue. So Quintero staging இருக்கு. First stageல வந்து ரொம்ப mild changes மட்டும் தான் வரும். So it will be like minimal oligo poly sequence. Second stageல பாத்தீங்கன்னா டோனருக்கு வந்து bladder தெரியாது. Bladder itself is not seen. அப்படினா என்ன அர்த்தம்? அந்த லெவலுக்கு அதுக்கு வந்து blood flow கம்மியாகி அதுக்கு bladderல urine இருக்காது. So that is second stage. Third one, they will start having abnormal Doppler. Fourth one will be ascites. And fifth one will be demise of either fetus. So this is Quintero staging. So TTTS, at least you should know there is a communication between the arteriovenous circulation of the placenta. One will be donor, one will be recipient. So donor la vandu thanni koranjirum, idhula vandu adhigamaidum, and further it can lead to demise. So this is very, very important. Basic, at least you should remember. And laser coagulation ablation is one of the treatment for your TTTS. Okay. So what is trap? So one complication which I told is TTTS. What is the other complication which you know? Monochorionic twins or complications. TTTS, conjoint, yes, I agree. Where enna theriyala? What is trap?
Twin reverse
And what is TAP? Twin reversed arterial perfusion. What does this mean? Same thing. So there can be a communication in the vasculature. So oral papa will be this normal papa. Okay, but again, this will be the donor, and this will be giving this blood supply to the other twin, which will be a acardiac twin. So it will be a lower part of the body mattum dhaan adukku develop aayirukku. Okay, so in the twin la cardiac irukadu, upper part of the head brain adum irukadu. So enagum, so all the nutrients will be like going to this twin, which will be or monster mari or amorphous monster mari இப்படி வளர்ந்துட்டு இருக்கும். இதுக்கு கால் மட்டும் இருக்கும், ஹார்ட்டும் கிடையாது, தலையும் கிடையாது. ஓகேவா? So only the lower part of the body is developed for this twin. So this will be the recipient twin. இதுக்கு எல்லா நியூட்ரிஷன் கொடுத்துரும். So again this donor twin will become very smaller. So இங்கேயும் வந்து same thing, லேசர் வச்சு இந்த கம்யூனிகேஷனை வந்து நீங்க வந்து இது பண்ணிட்ட அப்படின்னா வந்துட்டு this will go on with a good pregnancy. So this is trap sequence, which is twin reversed arterial perfusion syndrome. Okay, what is TAPS?
Twin anemia polycythemia sequence.
Excellent. Twin anemia polycythemia sequence. See, at least you should know these names. Okay, if you answer very well, definitely all these things can be asked. Idu enna, it is similar to your TTTS, but in a milder form. So growth variations irukadu, oligohydramnias varadu, but one baby will be giving the blood to the other baby. So appa blood kudukra baby ku enna agum, blood flow kammi aidum, so adu anemia aidum. வாங்குற பேபி என்ன ஆயிடும், பிளித்தோரிக்கா இருக்கும். So that will become polycythemic. So இது வந்து it's very, very difficult to diagnose antenatally. எப்படி வந்து அனிமியா ஆன்டிநேட்டலா பண்ணலாம்? கண்டுபிடிக்கலாம்.
Middle systolic velocity.
Yes.
Sorry,
So
peak
one
systolic velocity.
when you do Doppler, MCA PSV will be elevated in an anemia. அப்படி மட்டும் தான் கண்டுபிடிக்க முடியும். இல்லனா at birth this baby will be pale and this baby will be plethoric. So அப்படி கண்டுபிடிக்கலாம். So this is traps. These are like taps is also very very rare. So if you at least understand TTTS, that is good enough. Okay, so cord entanglement we have told. Okay. So other than that, what else did I wanted to tell you? Fine. So what are all the most common presentations you know in twins? என்னென்ன மாதிரி present பண்ணலாம் twins? Cephalic, அப்புறம் cephalic breech,
cephalic transmission.
very good. So cephalic, which is the most common? எது ரொம்ப common?
Cephalic.
Yes, excellent. Cephalic is the most common type of twins. Okay, so at least something you should know about that. Okay, so what else should I ask you about? Yeah, so pregnancy la twins management, caloric requirement, twins க்கு எவ்வளவு extra calorie தேவை? எவ்வளவு extra calories? Excellent. 300 extra அவ்வளவுதான். So ஓவரா திங்க வேண்டியது இல்ல. 300 extra kilocalories extra is enough. அதே மாதிரி அயன் இன்னொரு பிரெக்னன்சிக்கான எலிமெண்டல் அயன் மாதிரி. So 60 to 100 milligram elemental iron okay. அதே மாதிரி folate 1 milligram of folate extra போதும். ஓகேவா? Fine. So twin delivery, normal delivery கொடுக்க போறீங்க. How will you manage twin delivery? Patient is come in labor. She's there. What are you going to do? டக்குன்னு வரணும். ட்வின்ஸ்ல என்னென்ன காம்ப்ளிகேஷன், இன்ட்ராபார்டம் போஸ்ட்பார்டம் காம்ப்ளிகேஷன் என்ன சொல்லுங்க பாப்போம். then you'll know what all to be done. ஓய் இருக்கீங்களா? நான் மட்டும் பேசிட்டு இருக்கேனா? guys
Hello, ma'am.
சொல்லியா? எல்லாரும் இருக்கீங்களா போயிட்டீங்களான்னு தெரிய மாட்டேங்குது எனக்கு. ட்வின்ஸ்ல காம்ப்ளிகேஷன்,
இருக்கும்,
what
ma'am.
is the dreaded complication? Tell me.
Cord prolapse.
Over-distended uterus, cord prolapse. Very good. So mal presentations இருந்துச்சுனா cord prolapse வரும். Okay, what else? Abruption வரலாம். Okay, PPH வரும் கண்டிப்பா. ஏனா வந்து over-distended uterus சடனா வந்து வராது. So இப்ப abruptionோ PPHோ ஆச்சுனா bleeding நிறைய ஆகும். So அப்ப என்ன ரெடியா வெச்சுக்கணும்? blood products வந்து கேட்டு வெச்சுக்கணும். So what is your blood group அப்படிን patient கிட்ட கேட்டுட்டு to keep ready with the blood products, very very important. So first thing which you will do is IV lifeline with the wide bore cannula, wide bore வெச்சுக்கணும். Okay வா? So 1 to 2 lines வெச்சுக்கணும். blood products ஓட availability கேட்டுட்டு reserve பண்ணி வெச்சுக்கணும் too. and analgesia epidural இல்லனா வேற type of analgesia வெச்சுக்கணும். anesthetic வந்து backupல வெச்சுக்கணும். anytime you can have a complication, you can need that. skilled or senior obstetrician கண்டிப்பா வேணும். so you should tell that like a big senior வேணும். நம்மளே வந்து manage பண்ணிக்கலாம் அப்படினு இருக்க கூடாது. skilled obstetrician definitely வேணும். and எத்தனை neonatologist வேணும்? 2 பாப்பா. so 2 at least neonatal attendants 2 பேர் வேணும். okay, so will we induce for twins? twin delivery induce பண்ணுவோமா? usually they go into spontaneous labor. அவ்ளோ over distendedல ஓரளவுக்கு by around 37 to 38 weeks they go into labor. so there will be no indication to induce them. so they'll go into labor. if at all you can do an ARM, மத்தபடி வேற எதுவும் augmentation பண்ண மாட்டோம் when 2 papas inside. okay va? so fine. so எந்தெந்த patient க்கு normal delivery allow பண்ணுவோம்? when will you allow normal deliveries?
Both cephalic.
First twin is head.
First twin cephalic. Very good. So second twin, even if it is breech or transverse, we can allow for normal delivery. So first twin cephalic. Okay. Now coming to when will you do cesarean section directly?
First
இப்பதான்
is
கண்டி-
First
First.
twin.
Excellent. First twin non-cephalic. Head இல்ல. breacho, transverse layo, obligo, என்னமா இருந்தாலும் you are directly going for cesarean section. What else? If it is more than twins, triplet, quadruplet, எதுவா இருந்தாலும் you will go ahead with cesarean section. Okay, what are all the indications for cesarean section in second of the twin? So imagine in the twin, first baby head இருந்துச்சு, cephalica deliver ஆயிடுச்சு. இப்ப second twin வருது. So what are all the indication for cesarean section in second of the twin?
Cord prolapse, ma'am.
Excellent. Cord prolapse, வேற
Fetal
abruption,
distress.
fetal distress, வேற இது வந்து ஒரு big
Closed
baby.
cervix.
Yes. இன்னொன்னு வந்து your cervix get closed or it thickens and closes after the delivery. You are not able to deliver that. Then you are going to do the second of the twin cesarean section. Okay. What will be the interval between the delivery of both the twins? Inter-twin delivery interval.
Less than 30 minutes.
Usually it is 30 minutes. Okay. But some guidelines say as far as the second heart rate is better, இதோட FHR நார்மலா இருக்க வரைக்கும் you can allow for normal delivery. There is no specific things to say that it has to be delivered. Okay. So let us imagine this first baby cephalic. Your second baby is come as breech. What are you going to do? Breech. சரி, second twin cephalic. என்ன பண்ணுவோம்? Allow vaginal delivery. So normal vaginal delivery. If you need, you can put ARM. You can start Synto. ஏன்னா இப்போ ஒரு பாப்பா தானே இருக்கு. So you can Synto and you can try for normal vaginal delivery cephalic. Okay. Second of the twin breech. What are you going to do?
Breech extraction.
Yeah.
ECV.
Assisted breech delivery. Okay. Now second of the twin is transverse. What are you going to do?
Internal podalic version.
Directly. First we try external cephalic
External
version,
cephalic version.
and if it is not working, then you do internal podalic version and
Breech extraction.
breech extraction. What is the difference between breech extraction and assisted breech delivery? Breech extraction and assisted breech delivery.
We are allowed to deliver up to umbilicus in assisted breech delivery, ma'am.
Okay. See, assisted breech delivery is you allow the mother to bear down and you help her wherever assistance is needed. Okay, wow. Breech extraction is a place where the mother is under anesthesia. Okay. So, appada you can do internal podalic version. Sadana uterus varaikku kaiya ulla vittittu thirupadana mother will go into pain shock, rupture uterus and she will die. Okay, so internal podalic version is always under anesthesia. So under anesthesia, can you think a patient can strain? முடியாது இல்லையா? Anesthesia கொடுத்த பிறகு. So அதனாலதான் internal podalic version is always combined with breech extraction. And the only place for internal podalic version in modern obstetrics is second of the twin in transverse line. இது வந்து மனப்பாடமா தெரியணும். So can anyone repeat the same lines? I would like to hear this. Indication for
Only indication for internal podalic version is
version in modern obstetrics
second twin in transverse line.
transverse line. Okay, and internal podalic version மட்டும் சொன்னா it's incomplete. நீ திருப்பின உடனே பேஷண்ட் பேர் டவுன்லாம் பண்ணிட்டு இருக்க மாட்டா. நீனே பாப்பாவை பிடிச்சு காலை பிடிச்சு திருப்பி கொண்டு வந்து காலை அப்படியே பிடிச்சு டெலிவர் பண்ண போற. So internal podalic version, breech extraction. So these are the things which you should remember. Then definitely there will be a discussion about PPH, active management of third stage of labor. So இது எல்லாமே வந்து you should be very very clear. In a twinsல இது எல்லாமே வந்து without discussion they will not leave you. Okay ba? So is there anything else you want to know? Maybe we'll discuss PPH and other things later, not in this class. In order we can always manage with APH, PPH and all. So is there anything else if you want to know? We'll see. Otherwise, we'll call it a day. Anything you want me to tell? Anything you want me to explain? Guys? Hey, தூங்க கூடாது. எந்திரிங்க எந்திரிங்க எல்லாரும் எந்திரிங்க.
தூங்கல மேம்.
பண்ற மாதிரி எக்ஸசைஸ் பண்ண சொல்லுவாங்க எல்லாரையும். அப்புறம் வீடியோலாம் உட்காந்துட்டு நானும் உட்காந்து பார்ப்பேன். ஏய் தூங்குறீங்களா எல்லாரும் அப்படின்னு. ஓகே. சோ வேற எதுவும் இல்லையா டவுட்ஸ்?
No ma'am.
Okay. So I hope you all understood அப்படின்னு நான் நினைக்கிறேன். So and there are like sorry கேக்கலப்பா.
Cephalopelvic disproportion.
Yes. Cephalopelvic. புரிய ட்வின்ஸ்ல எப்படி டயக்னோஸ் பண்றது?
Chat பண்ணு பிரவீன்.
தனி கிளாஸா எடுக்கணும்.
Sure. Kandipa CPD tani class kandipa edukla. Okay. See, one or two things which I wanted to tell you is, when twins, you should remember, because if your consultant who comes for the exam is ART specialist, IVF specialist madri, if they are there, appana vandittu there are certain things your consultant are going to ask. Okay. One thing is, now twinning is less nowadays. Why? This you have to know, you have to remember. These are certain important things which you'll be asked nowadays, because in and out we are doing. When they started IVF, maybe say around in the 1990s, okay, till 2000 the twinning rate was very high. Okay, now the other higher order pregnancy, especially triplets and other things, were very high. Ipo the triplets are not happening at all, and even twinning is less. Do you know anything about this? Because recently we have started applying this SCTs, single embryo transfers. Okay, when we put itself, you put only one embryo, so the chances of twinning is very, very less. Okay, the second thing you should remember about ART is, what is a blastocyst? Anyone knows what is blastocyst? End the day embryo is called blastocyst.
20.
Okay. Hey, இது நார்மல் பிசியாலஜி, உங்களுக்குலாம் தெரியணும். சோ நம்மளோட இம்ப்ளான்டேஷன் ஃப்ரம் த டியூப்ஸ்ல இருந்து நம்ம யூட்ரஸ்க்கு நடக்குது இல்லையா? எந்த ஸ்டேஜ் எம்ப்ரியோ? day 5 or day 6 embryo is the blastocyst. Okay. So implantation occurs in day 6 after ovulation. Okay. Your day 5 embryos are called blastocysts. Okay, wow. So if at all a twinning occurs in a blastocyst, so imagine this is the blastocyst. So in the multiple cells mature blastocyst embryo varudha. Idhula twinning nadakuduna, what kind of twinning will it be? It's the blastocyst. இப்பதான் நம்ம டேஸ் எல்லாம் வச்சு படிச்சோமே. Day 3 monochorionic twins. So அதனால you should remember. So if it is a single embryo transfer, especially if it is a blastocyst, and if that divides into 2, it will be a monochorionic twin. Okay ba? So single embryonic transfer la renda pirinjaduna adu monochorionic twin varum. So these are certain things which you should remember. And idella recent ART practices. So if somebody ask IVF la twins kandipa varma அப்படினா என்ன சொல்லணும்? 2-3 embryo போட்டா தான் வரும். Single embryo போட்டா most of the time it will not split up. And in case day 5 blastocyst split ஆச்சுனா monochorionic twinning வரலாம். So these are certain simple things which you can remember. Okay. So if there is anything else, like if you want to know more about ART, I don't know whether they will ask you an exam, sir. IVF and idella romba kekka maatanga. Ideally, they will not ask for undergraduate level. So if there is anything you want to know, then you can tell me. I will get you the details, sir. Inakojam eduthuna varala. Okay, va? Cherry. Okay, guys. So we will call it for today. So innikku we will finish the class. See, twinning is a very, very important topic. So finally, and very, very easy topic, okay? In the questions mattumதான் கேட்பாங்க. There is nothing more you can add to this. இவ்வளவுதான் questions இருக்கு. But if you don't, if you don't know these answers, then it is going to be a difficult topic. So it's a very easy thing. It's very easy to pass if you know these ones. So இன்னைக்கு போங்க, please try to refresh, try to read today so that you will understand it better. Okay, ba? So maybe next
Okay,
class
ma'am.
we'll see CPD. We'll discuss, doctor. Maybe if you have a case, we'll present CPD. We will definitely discuss CPD. Shariya?
Okay, ma'am.
Okay, pa. Take care then. Okay,
Thank
bye.
you, ma'am.
Thank you, ma'am.